Compare all of the interferons and Copaxone, which has a different mechanism of action but very similar sort of efficacy. This is real-world data from what thing called MS-BASE. So this is an international database of over 35,000 patients from around the world now, looking at simply how they've gone on various treatments and trying to match them for baseline characteristics. The basic story here is that the outcomes from the various drugs are very similar. So we think that these drugs are only modestly effective, but they're all very equivalently effective and are certainly better than being on nothing. Teriflunomide is a new oral tablet which has very similar efficacy to the interferons and Copaxone. But it does have some adverse effects. None of them are really serious or life-threatening particularly, but some of them are things you probably could do without, like your hair falling out and getting a neuropathy, which gives sort of tingling in your feet. And therefore, I think it's not going to be probably quite as popular as the injectable agents at the moment. But certainly for some people, it's going to be appropriate. But we do have these two tablets, and I understand that fingolimod has just recently become available in New Zealand. We've had it available for a little while in Australia. And it's proven to be a very useful drug. It's certainly very effective. So it reduces the chances of relapses by about 50%, and it reduces the chances of getting more disabled by about 30%, again, over just a 2-year period. The data for dimethyl fumarate, or Tecfidera, is almost identical. It's quite funny, if you actually rearrange these two sets of graphs by inverting them and doing a few other manipulations, you can almost lay them over each other, and they match up almost perfectly. So there's no doubt these two drugs are very effective. In terms of side effects, there are some issues with both of them, but again, nothing too alarming. With fingolimod, you have to worry about heart conditions and asthma, because it can make both of those worse. And you have to monitor people for the first 6 hours whilst they have the tablet because of potential bradycardia or slowing of the heart. There's also about a 0.5% chance of developing a thing called macular edema, which is a swelling at the back of the eye. No one's ever had any problems with their vision as a result of this, but it's something you have to monitor for before and 3 months after starting treatment, and if it appears, you might need to think about stopping therapy. With Tecfidera, it causes some GI side effects, so some gastrointestinal disturbance, a bit of nausea, mainly sort of a bit of alternating diarrhea and constipation in some people, and also flushing attacks. Those occur to a significant degree in about 20% of people, and they tend to persist, and in about 10% it's so severe they can't carry on taking it. The only other problem that has now unfortunately emerged with both of these drugs has been a single case of PML, so this rare brain infection caused by the JC virus, which has been the bane of another drug I'm about to talk about, Tysabri, so I'll talk about that a little bit more in a second. But unfortunately, there's been a single case now with both of these drugs in people treated for MS. And the risk seems to be very low for that, but it clearly highlights that opportunistic infections, as we call them, with these immunosuppressive agents is going to be a low-level problem. Also, we were told last week, in fact, that there's now also been 6 cases of cryptococcal meningitis with fingolimod, which is a very rare form of meningitis. It's actually reasonably treatable, but there has been one of those 6 people died from that. So these late problems are starting to emerge with some of these drugs. So natalizumab is this monoclonal antibody that blocks a receptor that lymphocytes need to get into the brain. So it's a very clever drug. So it simply stops the inflammatory cells getting into the brain. And it very significantly reduces the chances of relapses by 70%. Again, a very dramatic effect on disability, and this was really probably the first drug we ever had that you could demonstrate people actually improving. So actually getting better in terms of their level of disability. So there's no doubt it's very effective. It requires an infusion once a month, which is very well tolerated. So there are no real day-to-day side effects with this drug at all. The only problem is this thing, which is PML. So progressive multifocal leukoencephalopathy, which is caused by this thing called the JC virus. The JC virus is a completely benign virus as far as we can tell. It lives in the kidneys of about 50% of the people in this room. It normally causes no disease at all. But if you become immunosuppressed or your brain becomes immunosuppressed, in this case with natalizumab, then this virus can get into the brain and cause this infection. And in other circumstances of severe immunosuppression for chemotherapy for cancers, for example, or in people with HIV/AIDS, although we very rarely see that now, this disease used to be almost invariably fatal. Natalizumab has not been quite so bad in that about a fifth of cases have died. The remainder, about a third, do okay. About a third are moderately affected and a third are sort of severely affected. The good news over the last 4 or 5 years has been that we can now actually test for the JC virus. So we can look in people's blood for the antibodies against the virus. And there's one lab in the world in Denmark that does this. So they do this JC virus stratify test, and they can basically stratify your risk. If you're negative on the test, you've got probably less than a 1 in 10,000 risk of developing PML. So essentially it means you're not going to get PML. If you do have the virus, the chances of developing PML sort of after 2 years becomes close to 1 in 200, which I think for most people is probably too high a risk. If you've had prior immunosuppression, the risk goes up even higher. So unfortunately, this means that I think for people who are JC virus positive, this is not a long-term treatment option. But I certainly have a lot of people who are on this, JC virus negative, and they're all doing extremely well. In fact, you just virtually never see any new lesions on this drug, and if you do, you can probably presume it's not working, which happens in a small number of people, probably because they produce antibodies against the antibody. And then, just in the last year or so, or in fact from April in Australia, but last year in other parts of the world, we've had this drug alemtuzumab. So this is a drug a colleague of mine, Alistair Coles, was working on in Cambridge when I was there in the late 90s. And this is another monoclonal antibody, so a man-made antibody. In fact, it was the first man-made antibody in the world. It was originally a mouse antibody. Unfortunately, when they used that in humans, it caused a severe reaction, so they stopped using it very quickly, but they then did this thing of humanizing it, so they specifically engineered it to look more like a human antibody. And that means it was much better tolerated. And this antibody is against a thing called CD52. We don't know what CD52 does, but it's a protein on lymphocytes. So it identifies lymphocytes, targets them, and it's a so-called lytic antibody in that it kills the cell. So it literally destroys all of your lymphocytes. And it does that very effectively. If you administer this drug to someone and you give 5 courses over 5 days, immediately after that you cannot detect any lymphocytes in the blood at all. So this effectively does the same as a bone marrow transplantation without the risks of a bone marrow transplantation. It eradicates your immune system. It then relies upon your bone marrow to replenish those lymphocytes. And we think that basically it just resets your immune system, and the chances of it coming back in exactly the way it was before and being very reactive against brain tissue seems to be very low. So we think that that's why it works very effectively in MS. And so again, in terms of reducing relapses, and this was a trial against Rebif, one of the beta interferons, so this is not against people receiving a placebo, this is against an active treatment. It very significantly reduced the risk of relapses. It again significantly reduced the rate of disability and actually showed evidence of people improving, and also showed significant change in brain volumes. There are some side effects, there are some issues. About a third of people with this treatment develop autoimmune thyroid disease, usually after 2 or 3 years. And it's actually most commonly hyperthyroidism, or an overactive thyroid, which is generally pretty rare. It is very manageable though, so hypothyroidism has been very treatable for a long period of time. Certainly be very, very unusual for anyone to ever die of autoimmune thyroid disease in this modern era. Usually it requires either treatment with medication, or if it persists and your thyroid remains overactive for a long time, sometimes you actually have to have your thyroid gland removed, and then it means going on thyroxine replacement for the rest of your life. There's this thing called ITP, which is another autoimmune disease that affects the platelets in the blood that normally cause our blood to clot. And if you have an autoimmune disease of that, your platelet count goes down very low and you're at risk of bleeding. And in the phase 2 trial of alemtuzumab, before they realized that this was a problem, there was actually one person who died from a brain hemorrhage before they realized this complication. This now means that you have to have blood tests done every month following this treatment for at least 5 years to monitor for this low platelet count. And if it develops, it's again very treatable with steroids. And then there's this very rare thing called Goodpasture syndrome, which is another autoimmune disease against a basement membrane that's found in the kidneys and the lungs. So this causes kidney disease and lung disease. It's a very, very rare in my entire career. I've only ever seen one case of this when I was training. And it occurs in about 0.5% of people after they've received alemtuzumab.